Dear viewers, a hearty welcome to all of you to the School of Laboratory Medicine. This is a small poetic presentation which tells us about the chemistry and the clinical significance of HbA1c. Let me introduce myself. My name is Usha Anand. I'm a biochemist by qualification and profession. I'm passionate about teaching, about biochemistry, and last but not the least of them all, about poetry. This presentation is an amalgamation of all of these. I shall now read out the poem, The Clinical Chemistry of Glycated Hemoglobin, which was published in the journal called Clinical Chemistry in the year 2010. When proteins are surrounded by glucose molecules along sites in the plasma and the cells where they function and reside, they are forced to interact with them whether they like it or not. Some of them get entangled and are obligated to tie the knot. The blushing hemoglobin locked up within the erythrocyte is embedded in the midst of glucose with its sugary delight. The amino terminal valine of its beta chain is enticed to react with the aldehyde group of glucose. It enters into a secret pact. Unholy alliances are forged over the lifespan of the erythrocyte. The binding with the mighty glucose becomes irreversible and tight. Slowly, more molecules of hemoglobin get irrevocably glycosylated. A number of minor variants of the original molecule get created. These post-translationally modified forms were called HbA1a, A1b, and A1c, based upon their rates of migration and elution using techniques of chromatography. Biochemists soon realized that these could be used to peek into the metabolic past. They had worked on the fact that beyond 120 days, the erythrocytes don't last. The immediate task was to identify, specify, and characterize the measurand at this stage so that the biochemists, the industry, and the diabetologists are on the same page. What is that we are going to consider as the biomarker of glycemic status in this case? Since there are a host of lookalikes and distractors, and what we need is a spade of A's. We are all aware that the major adult hemoglobin has a tetrameric structure. A pair of identical alpha and beta peptide chains interspersed is its unique architecture. To label it as HbA1c, glucose attached to one or more beta chains must be seen. Glycation at other sites are not relevant, such as the one at lysine. So what are the issues that arise if we need to segregate and estimate HbA1c and that alone? What are the physicochemical properties of this molecule that is exclusively its own? The charge carried by HbA1c has been targeted in techniques of electrophoresis and chromatography, while immunoassays are based upon specific antibodies which fit into it like the proverbial T. HbA1c should be assayed by the best method possible. The calibrator is authentic and, most importantly, traceable. The results of control samples falling well within the boundary lines, making sure that accuracy and precision are not on the decline. Its levels reflect the time averaged blood glucose for the preceding 8 to 12 weeks. It is a good index of the glycemic status, gives a historical overview, so to speak. However, if the erythrocytes have a reduced lifespan, The result of the test could be skewed. Also, if the patient has received a blood transfusion, the report with skepticism should be viewed. The reference range for HbA1c is 4 to 5.6%, you may recall. In the pre-diabetic condition, between 5.7 and 6.4%, the values fall. In diabetes mellitus, values equal to or greater than 6.5% is seen. The clinical decision value is 7% and indicates when the clinician would intervene. Remember that HbA1c is just a surrogate marker of the diabetic state. There are several functional proteins that pick up glucose as their mate. Several proteins of the kidneys, the nerves, and the eyes, to name a few of these, are all a prey to this phenomenon and are responsible for the complications of this disease. To control diabetes and keep its complications at bay, the rise in HbA1c should be detected without delay. It is not just simple hyperglycemia. There is a lot at stake. The nexus between glucose and proteins we must help break. So now we come to the summary of the whole topic. We look at the take-home points. The first one is the measurand. The measurand is HbA1c, a particular form of glycated hemoglobin. This HbA1c is an adduct that is formed between the hemoglobin within the erythrocyte and the glucose molecules surrounding it. It represents the time averaged blood glucose for the preceding 8 to 12 weeks. The analytical methods that are commonly used for the measurement of HbA1c are HPLC, capillary electrophoresis, as well as immunoassays, which are specifically directed at HbA1c. The reference range for HbA1c is 4 to 5.6%. That is in health. In the pre-diabetic state, the HbA1c is 5.7 to 6.4%. In diabetes mellitus, the HbA1c levels are either equal to or greater than 6.5%. What is the clinical significance of HbA1c? It is used to monitor the efficacy of treatment in patients with diabetes mellitus. Before we end this session, let me pose a couple of word puzzles. The first one is, the price is good if it is on the target most of the times. That's a 9-letter word. The second one is, if you take a tour all alone, you might have to lie outside the fence. This is a 7-letter word. These words would be the clue for the next presentation. Thank you for your patient listening. We look forward to seeing you again in our next session of the School of Medical Laboratory Sciences with another poem. Your feedback is solicited. Here is my email ID. Thanking you once again and hoping to see you soon.